Thank you, Dr. Kemunto, for agreeing to be with us and answer a few questions for our YouTube channel as we commemorate our 10th year anniversary as the retreat. Asante sana. Now, we just wanted to pick your mind on a few issues concerning mental health in Kenya and the place of mental health in substance use disorders. And looking at some of the patients that you've sent our way, we realize that there have been a few cases of schizophrenia. And schizophrenia is quite a strange disease to most of the public. So in a man's basic language, how would you describe schizophrenia?
Well, schizophrenia, I think in a man's basic language is what people think is Wendawazim. But they assume that mental illness is generally Wendawazim, not knowing that somebody who has psychosis, it's only an aspect, a 1% aspect of mental illness. So schizophrenia, if I would describe it, it's when a person loses touch with the reality. That is the actual thing that happens. And when they lose touch with the reality, they start presenting symptoms that are bizarre. Majority of them are the type that will hear voices that other people are not hearing. And when you see them on our streets, they tend to talk to themselves. They tend to be addressing things that are not there. They will also, a few of them may see things that are not there. But the most significant thing that you notice with schizophrenic is the disorganization of their behavior. In the sense that showering, the normal habits that we have as a human being, remembering to be clean, changing of clothes, that will be affected. They tend to repeat the same clothes, they tend to not be aware of how they look or how they are too dirty, and they remain in that nature. On top of that, there are people who have issues with socialization. A parent will tell you that my child will sit by themselves, they will be inside the room, or they will stay somewhere without movement. They don't have the proper interaction skills like everyone of us. They cannot sustain a conversation. And that means that naturally you have to be the person to reach out to them than the other way that we are used to. The conversations tends to be one-word answers, what we call monosyllabic. You ask the question, they answer, and then they pause and wait for the next one. It is not an engaging conversation. Beyond the bizarreness, they tend to be the kind of people who will be having some delusions. They will tell you that people are attacking them, they're being monitored, especially where there is a room or a place with CCTV. They'll feel that there's communication coming through, or they'll feel that things are being stolen from them, especially the thoughts or words inserted. And sometimes then behavior-wise, when they're trying to prevent themselves from that, they'll close their ears or they'll tend to wear a marvin so that that kind of control is not there. So you find that the interaction, the delusions, the hallucinations, and their presentation will change. And this also affects their functionality. Because schizophrenia is a chronic condition that is also progressive. So they'll tend to they'll be very good before the illness sets in, which a majority of the time we find that for the boys is between the age of 15 to 25, but for girls is a bit much later, maybe from 19 to 29. And this is a child, somebody would say, was originally very intelligent, high achievers, but all of a sudden they cannot be able to keep up with school, performance is failing, and they're not able to function at all. Parents would say that this is a child who's been lazy. All of a sudden they could be able to do something, but now you have to keep motivating them. Oga, toka hapa, keti hapa. In fact, they'll be in their room, there's vyombo kwa meza, but they don't have that initiation or motivation to do anything. And in what, in our terms, we call a motivation kind of syndrome, but apparently we describe it as a new sudden laziness. So.
We find that most, especially in our context, the African context, most families will believe there is witchcraft or somebody has been cast. I don't know if you experience, you've encountered such, and what would you say to them?
To be honest, I think culture and the myths surrounding our culture have been the greatest inhibitor to the progression of mental health awareness. Because there's a strong belief, especially in some cultures, if you call the Kisi, they believe that it is witchcraft that has changed someone to be like that. And that means that a person with mental illness takes very long before intervention is done, or they are subjected to some kind of treatment that is not humane. For example, we see people tying them to trees, locking them in houses because it's a bad omen, or they are ashamed of this kind of people. And yet, mental illnesses are treatable. So that has inhibited health-seeking behavior.
And even when they seek help and treatment, do you think culture still plays a part in appearance communication, for example?
It truly does play a big role, because most of the time you find that culture and religion becomes one of the inhibitors of compliance, because you find most patients will go back and there'll be someone who will be like, no, don't take that, try this mishiti shamba, let's go to the witch doctor and do some tattooing and totems and all that. And by the time they realize that all this is not working, either the illness has progressed, or most of the time it's too late, especially for those who are suicidal or depressed. We lose a lot of our clients in that manner. So truly it does affect compliance.
It's interesting you bring out the aspect of religion, because we've had patients or clients who, before they finally get treatment, they have gone to religious leaders, they have been prayed for. So what would you tell that person who are religious and they feel probably prayers would work, and would you advise them not to be religious? What's the divide here?
To be honest, I like religion, and I do believe that religion is a great support structure, but it is not to follow religion completely. It's that we work together with treatment, hand in hand with religion. Because as we've come to find that most people find peace when they pray. Most people find peace when they believe that there's truly a higher being who's there watching them. And even when they go speak about their problems, they tend to find a release. But it does not mean that religion is the entire goal or the treatment form that can be used, especially for someone who's having a chemical imbalance in the brain. I believe that if we work closely with religion, a lot of people might be helped. And in fact, there was a study that was done that showed that a majority of our patients first go to religion before they come to us. So it means that if we do a lot of health talks and also psychoeducation to our religious leaders, it may be a bridge in the gap, because we might actually reach out more to the patients whom we don't get to see, because a majority of them will be praying, will be asking for help. And then the study that was done in 2019 showed that most of our patients actually commit suicide after going to religion and not getting the help they seek. So if we could bridge that gap and be able to reach out to these guys, we may be able to assist many more people. So for me, I believe that we should be able to support, as religion should remain as a support structure, while treatment should continue being continued, and there's compliance. So we work together.
So in short, we should supplement each other and complement each other.
Yes, correct.
All right.
Yes.
Now again, probably the final question, Dr. What is the link between mental health and substance use disorders? Because we find that, for example, like for us, the retreat, we deal, most of our patients come in with comorbid states. So what would you say is the link? Is there a link, first of all?
There's a big link between mental health and substance disorder, because most of our clients will always have an underlying issue. But because they do not know where to go for help, they will always try to cope. And remember, some mental illnesses, or maybe a majority, does affect your judgment and your decision making. And most of the time, you will choose what is not good for you. So while we are having that area, or the cognitive aspect of that compromise, and you're dealing with the low mood, and all what you know is, if I take cannabis, or if I take weed, it will uplift me, or if I drink alcohol, I will run away from my issues. You find that most of them will use alcohol as a negative coping mechanism. And you see, the problem with using substances is that it will give you a brief relief or a short-term relief, but further plunge you into the depths of the illness, especially if it's depression, or even contribute to a development of another comorbidity. For example, if you're using cannabis, then you end up becoming psychotic, or even getting a mood disorder. And you find that patients are stuck in that loop until they find help. And even when we're giving them help, patients with a comorbidity of substance abuse are very difficult to treat. And that's when relatives will come and tell you, how is it that this isn't working? Why are we having relapses and relapses? And it's because of that relationship with substances. It makes treatment very difficult. And if I may add, There are people who believe that maybe mental illness has a role to play when it comes to not even substance use, when it comes to people committing crimes. And it would be nice to demystify this today and say that there actually is no link between mental illness and crime. In fact, a study was done and it showed that the crime rate from 1990 to now in mental ill patients has not even increased in percentage. Most of the mentally ill patients are more towards self-harm than harming others. So when people see people in our jails, they think that mental illness has a high role to play. Or many times when you see a patient who's psychotic or has a mental illness, you're afraid of them. They have no risk towards you. In fact, the higher risk that we fight is because they have a high risk of self-harm. But the link between mental illness and harm and crime comes in when we have substance use. Because in substance use, those who are using and not sick, and those using and when sick have a higher risk of committing crime. Because to fuel that behavior, you find yourself committing crimes to be able to cover up or finance that behavior. But it is not because of mental illness in itself. Substance use is what has occurred here. And it doesn't have to be that you are sick to actually commit a crime. You could just be a normal user.
Alright, thank you. Probably finally, for parents, for example, so that they're able to catch these illnesses at the nick of time, maybe you would want to repeat to us the onset of the disease. Around what age should parents be more careful and more observant?
As psychiatrists, we say that the entire life of a person is very key. And a parent needs to be able to understand their child, especially the introverted kind of child, who we usually say is quiet, keeps on to themselves, and is not interactive, or probably harmless. And most of the time, as parents, we celebrate that kind of behavior. But that is linked to how a child, dependent on their age, if you start seeing a change on how they're behaving, or how they're able to function at the age of 15, especially for boys, and at the age of 19. If a child was quieter when they were younger, and then you start seeing them having this now becoming a functional issue, then it's very important to link that to schizophrenia, because most of the time they will start as children being schizoid in personality. And schizoid means that they're quieter, they're more into themselves, they have little interpersonal skills, or they will not be the kids who will look for friends. Friends are the ones who come look for them. Then at the age of 15, they will progress very well in terms of school and functionality. But at the age of the 15, you start to see different things changing in them. And even performance becomes key, because most of the time as parents, we notice performance other than behavior, or before behavior. Then if you link it also to that behavior and start to seeing either they're more fearful, they're more paranoid, they're not functioning well with others, they keep to themselves, they're more withdrawn, they're not showering. But now you start seeing they're talking to themselves and as if they're talking to things that exist and feeling those aspects of control. And it's important for this child to see a psychiatrist.
I know I've said the last question many times, but now this is the last question. Because what you describe, parents would say it's normal teenage problems. Because again, during that period of teenagehood, when these people are trying to form an identity, you see a rebellion sort of.
Yes.
So how do you distinguish between normal teenagehood development and when there is a mental disorder that's setting in?
In fact, when normal teenage development happens, children are more extroverted, children are more out there, they want to hang out with their friends, they don't want to be on their own. A schizophrenic kind of child will not be able to do that. In fact, now the bizarreness, the being withdrawn will be more worse, because you can even find them in a room which is dark and they're not switching on lights. That is not being rebellious. That is a child who's having bizarre behavior. The behavior is not in keeping with normal, like a teenager. While you're expecting this child to talk to you or trust you, this is a child who will be saying things that are not making sense. For example, they are being watched, there are people around them, there are people they're conversing with. That is not normal teenage behavior. This is a child who's describing hallucinations that are going on. When normal teenagers are so keen about themselves, they want to shower, they want to have presentation, they want the most current clothes. In fact, the fight will be for not providing enough. A schizophrenic will not be interested in showering in the first place. They will sit in the same clothes from day in, day out. You're the one to tell them, yo, you need to change, you need to wear something clean. They can even shower and return the same clothes. That kind of being very self-absorbed is not there. They are not even interested in themselves completely. In essence, they are careless. So there's a very big difference between a teenager developing and one who's developing a mental condition like schizophrenia.
Right. I think that has been very helpful, but I really appreciate your time.
Thank you.
And Asante for being with us through this journey.
Yes.
Asante.
Karibu sana. Mr. Mother, it was very nice to be engaged in this and to be able to provide more light into what most don't understand. But I believe that we are speaking more of mental health now than before, and if the journey continues, then we will actually not have issues. Many people will walk in and come to seek for help before it is worse. Yeah.
All right, Asante.
Karibu.